Hello, everyone. Greetings. Thank you for having me here today. I would like to thank the Conceptus team for inviting me. Being here on this stage with the greats of emergency medicine is extremely overwhelming. I am not Pablo Neruda, so I will have to use my notes. So I'm a family doctor who works in a northern remote part of Canada. I work in a hospital where we're all GPs and we cover the emergency room, the ward, the outpatient family medicine clinic, we cover dialysis, and we do home care services. So palliative care is really one of the favorite parts of my job. Palliative care was the first rotation that I did in medical school, and it has colored the way that I've approached medicine ever since. Right from the beginning of training, I was taught to remember these three things: that palliative care is something that should be available for all patients, not only those dying from cancer; that palliative services should start well before the end of life as the transition from cure to care is made; and that doctors, all doctors, regardless of their specialty, need some training in at least the basics of palliative care. So that brings us to today, palliative care emergencies. Now, a lot of you are probably wondering what on earth that even means. Surely if someone's in palliative care, there's nothing really that's going to be an emergency. We know they're dying. But this is where I need you to remember that there are two types of palliative care emergencies. The first type is in patients who are slowly dying of their underlying disease, but who get acute issues which could kill them quickly if they're not treated. But if they get their treatment, their prognosis could go on almost unchanged. And then there's the other type of emergency where patients could die a very unpleasant death from certain diseases and events if we don't know how to take care of these particular problems. So some of you might already be familiar with this graph. It's from the WHO. It plots out the ideal integrated approach to palliative care, where palliative care teams start to be involved really on in the process of the diagnosis, and then as the disease progresses and the focus slowly shifts from cure to slowing progression or to where quality of life is more important, the palliative team becomes more and more involved. The goal of this is that so at the end of life, the patient's not suddenly dropped into the care of a brand new team who has a whole new approach. So, for those of us who work in rural areas, so I work where this light works, but the big star at the top is where I work. Toronto's way down there, and then we're down in Santiago. So for those of us who work in rural areas where GPs do most of the work, and I believe that there are quite a few of you here today in that situation, it's often the same group of us who are doing all these different parts of the care. So the patient moves through time, and we shift the focus of our visits and our investigations and our treatments. And this hopefully leads us into a more seamless transition into end-of-life care. But of course, it doesn't always go smoothly. Because of that, let's just go through some of the common palliative care emergencies that are easy to recognize and treat if you think about them, even if you don't have extensive imaging or you have specialist access. And then we're going to look at some of the common end-of-life emergencies which we need to know how to navigate. Oops, sorry. So, and does anyone see a problem here? Well, that's right. Right there in the middle of the spine, there's a cancerous tumor pushing on that spine. This is spinal cord compression. You get compression of the vasculature that can lead to cord ischemia, or you can also have direct compression from vertebral mets, or if the vertebral bodies collapse because of either cancer or paraspinal masses. The main problem with spinal cord compression, particularly in the palliative patient, is failure of recognition. It can be extremely subtle, the presentations of this in the early stages, so you really need to be thinking about it if you're going to pick it up. Because if you don't pick it up, this could result in paraplegia or quadriplegia. And the neurological function of your patient at the time you make the diagnosis is the best predictor of how they're going to do after the treatment, so you want to catch this early. The most common symptom that this presents with, unfortunately, is back pain because it's pretty vague. And this can predate the sensory changes by weeks or months. So you get this band-like encircling pain that goes around the body. Sometimes it's worse with coughing or straining. And the pain is often positional, so those are sort of clues that you can use. They say it's worse when they're lying down, when they're lying on the couch. And a very important clue to really think about is this hard to control pain despite escalating doses of opioids. So if you've had someone who's had back pain for years because you know they've got mets in their spine, or they've had the pain for months and you've had it well controlled, and then suddenly they're needing more and more and more and more acute pain control, that can be a clue that maybe there's something else going on. So you get stiffness, and often before weakness, and you can get tingling and numbness, and usually that happens pretty quickly. It starts on the feet and it goes up. It can go to urinary retention and incontinence, and you can also get perianal numbness and poor perianal tone, and that's a very late symptom though. So I think we're pretty good at recognizing that if someone has the symptoms of very late neurological compression, but you want to try and catch this early. They might have altered reflexes, they might not. They might have pain with a straight leg raise, they might not. And remember, it can be asymmetrical. You don't have to have bilateral equal symptoms, so that's another clue. And you don't have to have a clear sensory level, because sometimes people are waiting to say, well, they've got clear delineation. It doesn't have to be like that in spinal cord compression. Oops, sorry. So how are we going to check for it? Well, MRI is the gold standard, and of course, I don't know about you, but I certainly don't have access to MRIs where I work. The nearest MRI is about, I think, 16 hours away, so we're not going to use that. We can use an X-ray, though. Plain film can work. You can see a lot with a plain film. You might not see the mass itself, you might not see the direct cause, but you could see things going on around it. You could see vertebral collapse, you could see fractures, you could see erosion of the pedicles. Those can all be cures. Again, if you suspect this, if you have a suspicious X-ray, then you're going to have a high index of suspicion for this. And the most important thing you do is definitive decompression. Now, we're not going to do that in our emergency department surgically or with radiation treatments, but we can give dexamethasone. Dexamethasone, 10 milligrams IV or sub-Q right away, and then you're going to give them a tapering dose for quite a while. You're also going to call your specialists, because maybe this is something that can be reversed. You can get them to a center, and then you're going to end up having them treated. And then they might have another few months to live. All right, so emergency number 2, superior vena cava obstruction. So this is a condition where you get return of the blood from the upper body to the heart is impeded, which then results in this severe upper body venous congestion. Luckily, this is much more manageable now, thanks to many of the radiation and chemotherapy options that we have, but it's still something that you might see. Early symptoms could be periorbital edema and facial swelling that is more obvious in the morning than, or if there's or later in the day. So the gentleman on the left is the early morning, and then the same gentleman a few hours later. So you can see quite a big difference. I'm standing right in the way, sorry. So you could also have coughs or dyspnea. And that's because you get laryngeal edema, or you might have actual tracheal bronchial compression of the recurrent laryngeal nerve, and you can get dysphagia or chest pain. All of this, you realize, are, of course, very vague, non-specific symptoms. So, of course, you're going to be thinking about lots of other things in this differential. But in a palliative patient who you know maybe has a mass in their chest, that's something you want to think about. Later on, you're going to see this engorged neck and chest veins, and a little clue can be that the chest veins are non-pulsatile. They could have tachypnea, they could be plethoric, upper extremity edema. These are all different signs. There's a gentleman there who's known for superior vena cava obstruction, and you can see this sort of very engorged swelling of the face and the upper body. Later on, you're going to get headache, blurred vision, altered mental status, seizure. So these have to be on your differentials if someone comes in with a seizure. And papilledema. I don't know about you, but I am terrible at seeing papilledema. But you know, if you can see it, I'm very proud of you, and you can come and teach me, because it's very hard to see. If you suspect it, there are a few things you can do, even if you're a million miles from anywhere. Raise the head of the bed right away, because they feel like they're drowning. They feel dyspneic, they feel anxious when they're lying down, so you want to sit them up. And you can give them benzos or opioids. Now, we often can get away with smaller doses of the benzos and opioids than we would use for pain relief. So just little, like 2.5 milligrams of morphine sub-Q can really help, or a small dose of a benzo. And then, like with most palliative care emergencies, initiate high-dose steroids. Dexamethasone. I swear I'm not being paid by the dexamethasone producers, but 16 milligrams PO or sub-Q once a day. And then you're going to contact your nearest oncology center, radiation or surgical oncology, and find out if there's a way they can decompress this. There's different things they can do. They can do stents or the SVC, and then they can try and shrink the mass. And if you're really stuck and if you're a long way from anywhere, you can try a diuretic. It's probably a transient benefit only, but it's worth a shot if you've got nothing else going on. All right, palliative care wounds. Now, if you think that a palliative or malignant wound isn't an emergency, I'm going to try and change your mind today. Because picture yourself in your patient's shoes, and you're soon going to realize that few things are going to worsen your quality of life more than something like this: an oozing, malodorous, painful, bleeding, malignant skin wound. Poor attention to skin care in the dying patient is going to result in pain, odor, swelling, reduced quality of life, and increased care demands for family and other caregivers. So this is something we really need to know how to take care of. Of course, remember, skin can only withstand compression for about 30 to 60 minutes, not longer. So in those patients who are immobile, we need to be very attentive to skin care. So our first branch point for taking care of malignant wounds is whether or not the wound can heal. You need to assess this. Now, if the patient's prognosis is like months to years, and they're eating fairly well, and they've got good blood flow to the tissue, and they're mobile, then healing is probably possible. So you can go down that route, and that's more of a traditional wound. But if they have a prognosis of days to weeks, like they're anorexic or cachexic, or the wound has inadequate perfusion, then you're going to go more with symptom control. And you're going to try and decrease these sort of uncomfortable, burdensome, often painful treatments. Remember, provide adequate analgesia. It's very important. And if the patient is really close to dying or this wound is never going to heal, don't attempt surgical debridement. This is not something that you would need to do for these patients. For a few little sort of tips and tricks for palliative wound care. First tip, never clean a palliative wound with any liquid that you wouldn't put in your own eye, okay? Because it's going to sting. So I don't recommend you pouring it in your own eye first. You can if you want, or you do it to your medical student. I don't advise that. But you can, that's a good benchmark, okay? Because you really don't want to put something really acidic into someone's eye or their wound. They can have lots and lots of exudate, so try and use absorbent pads. You can get these alginate dressings, and that can really help absorb a lot of the exudates. Because if you think about it, sort of dripping exudates onto your sheets or your bedclothes or to your loved ones, it can be very distressing for a patient and their family members. These wounds are at high risk of infection, superficial infection or deep infection, and odor is often the first sign of it. You can try topical treatment, right? Like this is just to help control the odor and the infection spreading. Putting some topical metronidazole inside a wound will do wonders for you. If they've developed a cellulitis or there's like an osteo growing, and depending on their prognosis, you might want to try doing systemic treatment as well, but at least some topical metronidazole in there can really help a palliative malignant wound. These wounds often smell really bad, and we know that. So one of the tricks that I use is I take a baking sheet, like you'd bake cookies on, you put kitty litter, the stuff that you use for your cat's caca, and you put that under the patient's bed. It absorbs the smells. Or you can take barbecue briquettes, the charcoal briquettes, put that on a sheet, like a cookie sheet or in a box, under the patient's bed. It's hidden, and it absorbs the smells, and it's amazing how well it works. Other things you can do if you're not in a hospital where there's oxygen, you can have a candle. Burning flames often really work, but don't do that in the hospital or in the emergency room. And the other things are having a competing odor. If you've got a patient in the emergency room and they're going to be there for a while, they're boarding, you're waiting to get them into a room, and they have a foul-smelling wound, you can try having a bowl of coffee beans, having a family member just bring in some coffee beans. It's amazing how good that smell is, and it can cover up a lot of other odors. Be careful not to spray like air sprays all over the place, because palliative patients are often incredibly sensitive to odors. And then there are the bleeders, like these little microvascular oozing wounds that can happen. So one of the things that I like to do is I take TXA, I dip it, some gauze into some IV TXA, and then I put it on the wound. And if it's painful, you can also use ketamine. And you can on the wound as well, and you can also use epinephrine. You take 1 in 1,000 epinephrine, you put some gauze in the little bowl, and you just slap it on, and it's going to help stop those. It's going to help the pain with the ketamine, and it's going to help the bleeding with the with either the TXA or the epi. So talking about bleeding. So these terminal hemorrhages can be extremely distressing, obviously, and these are the next few things I'm going to talk about are things that could happen to anybody. It doesn't necessarily have to be a patient who's known palliative care, but you could have a patient coming in and you realize that they're going to exsanguinate, and this is how they're going to end their life. Obviously, people with ENT, GI, or respiratory processes are higher at risk of this, but this could happen to anyone, and we need to be prepared for this, and we try to prepare our patients that this might happen as well if we know they're at risk, because 6 to 10% of patients with advanced cancer are at risk of a terminal hemorrhage. Clearly, this is distressing for everybody, patients, staff, healthcare providers, family, janitorial staff. Very important to anticipate the possibility of this happening. So what do you do if you have a small bleed to start with in a palliative patient? Well, a small bleed is a bit like the sentinel headache. It's the warning sign that this might be worse the next time around. So you want to remember that and help plan and prepare the patient. But first of all, you're going to do some basic first aid. You're going to do some pressure dressing, and then you can take the epinephrine-soaked topical dressings and put it on there. Ideally, you would also maybe talk to radiation therapy and see if you can do some interventional techniques to see if you could maybe stop these, the bleeders from oozing again. And my favorite, TXA. I don't know if it's available here in Chile. In Canada, we use it a lot for many, many things, but we have it, TXA 1 gram TID. For a patient who, if they had a wound like this and they were constantly bleeding, I'd give them 1 gram BID, and if it kept bleeding, maybe TID. All really useful tools. Now, so the patient who has, the patient who's had a sentinel bleed and where there is a terminal hemorrhage is certainly possible, you need to prepare the family, you need to prepare the patient that this might be the way that they're going to end up dying. Because you want to prepare them, but you also want to balance the anxiety that that's going to produce. They might be terrified to cough, they might be terrified to sneeze in case this is the moment where they actually start to exsanguinate. And so you need to explain to them that you're going to have something called crisis orders. And the goal of these crisis orders is to give sufficiently rapidly acting medications to deeply sedate the patient and prevent distress while they're dying. You're not stopping this person from dying. They are dying from this hemorrhage, but you were going to try and make sure they are unaware of this process. So preferably you're going to prescribe medications in terms of when someone's hemorrhaging. If you give it sub-Q, it's not going to work that well, or IM. If you had an IV access, you could use it, but a lot of our palliative patients don't. So I will often go with 10 milligrams of morphine and 10 milligrams of midazolam. You can do IMs, IV, sub-Q, and you repeat it every 5 to 10 minutes until they are sedate, until they are calm and they are out of it, because you do not want this person to be aware of what is happening. Remember, if they're not opioid naive, you're going to use double their breakthrough dose. If they've never had opioids before, I'd give them 10 milligrams of morphine, but if they've had it many times, then you're going to want to up the dose. A few other things that you can do and have prepared in the room of a patient who might have a terminal hemorrhage, and these are probably some of the most important things you can do, is preparation of the room. Having green towels or dark towels. Surgical towels absorb blood and the color a lot better than our white bed sheets and our white hospital towels, because there's nothing quite as alarming as white sheets with red blood poured over it, okay? It can be extremely distressing for all involved. So having things that are going to absorb the blood and not show it up. So same thing with sheets and pillowcases. If families are able to have their, even just a pillow from their home, this can be helpful. Having a warm face cloth for a patient who is dying of a terminal hemorrhage. Dying from a terminal hemorrhage is not like when you're dying from respiratory distress. You are usually quite cold when you're hemorrhaging, right? Because you are obviously losing all of your blood. So providing warmth in these patients as opposed to the other patients where we often provide cool air. Having emesis basins with face cloths inside. If they're vomiting blood or if they have a severe epistaxis and there's blood pouring into these metal bowls that we give them, it's an incredibly awful sound to hear someone losing their blood volume into one of these bowls. And I've had patients' families who have PTSD from the sound of the blood pouring in. So putting a face cloth in, it absorbs the splash, it absorbs the sound. Keeping the patient warm, another thing. So quickly, I'm running out of time, but this terminal distress, so this is, again, it's the same concept. It's you're giving some morphine, you're giving some midazolam, and you're giving, if they've got bronchial secretions, you're giving scopolamine. It's a little cocktail that you can just always use almost for any of the different indications. I'm just going to skip this one. Terminal pain crisis. If your patient has had been on the same opioid for a long time and suddenly their pain control isn't working, think about, of course, spinal cord compression if they're having back pain, but otherwise it might be a sign that they're developing tolerance to their opioid. So you might, if you have enough time in this patient's life, you might want to consider doing a rotation of opioids from morphine to hydromorphone or to another agent. But if you don't have that, then you might just need to increase the amount of medications that you're giving. And then one last concept I really want you to leave you with is something called total pain. So this is a clinical idea and sort of approach developed by Cicely Saunders, who was the founder of the modern palliative care movement. And this is something it recognizes pain as being something that is physical, psychological, social, and spiritual. But how do you treat that? I mean, we're really good at the morphine, the midazolam, but that's not going to treat someone's existential crisis, right? So remember that patients might be experiencing their psychological symptoms in terms of physical symptoms. So you might not find the physical cause of this, but you can involve professionals from other domains, traditional healers, elders, church leaders. All of these things are going to help. So that's my little guide to palliative care emergencies. If anyone has any questions, this is my disclosure, which I guess I should put at the front. Those are pictures from where I work. And then and that's my email and my Twitter account. I'm happy to answer any questions at any time. Thank you.